Cotswolds and Morecambe Bay Foundation Trust. I'm Andrew Stevenson, I'm Chair of the Trust. Can I welcome members of the board? Can I welcome members of staff attending for specific board items? Can I welcome members of public online watching the meeting? And can I particularly welcome two new board members, our interim Chief Operating Officer, Gavin MacDonald, and our new interim Chief Financial Officer, Leslie McLeod, both of whom started on Monday. So reserve the difficult questions for them. I've had apologies for absence for this meeting from Alison Cole, from Jalabani Nabele, and from Brian Webster Henderson. Are there any other apologies to be noted? No. Declarations of interest have been circulated, but just for the record, can I check? Leslie, nothing to add? No. Gavin, nothing. Perfect. Okay, the minutes of the Board of Directors meeting on the 6th of May have been circulated. Any comments or corrections? If not, are we happy to approve the minutes? Yep. Great. The action sheet and matters arising for the minutes has also been circulated. I believe everything is in hand. So if everybody is happy with that, we will move on to the first item of business, item 21, which is Board of Directors Patient Experience Report. So I'll hand over to our interim Chief Nurse, Lynn Wire.
Thank you, Chair. Well, today I'd like to introduce Sally Holmes, Lucy Hahn, Sharon. Claire is the matron who's come to support them today. So it's a really opportune time to bring this story, which is about the integrated wellness service at the Furness end of the patch. So this is a really key part of the reducing days away from home piece of work and around admission avoidance. And you're going to share Mr. Charnley's story. So I'm going to hand straight over to you to present your story. And then once you finish, there's likely to be some questions, but nothing that you can't answer. And it certainly won't be a grilling, so please feel nice and relaxed because we're all really interested in this service. Thank you.
Good afternoon. My name is Sally Holmes and I'm the interim team lead at the Wellness Service based in Barrow. Here with me today is Lucy Harper, who's one of the Wellness Service case managers and a case manager for the patient that we're going to present today, and Claire Earnshaw, who's matron for our service. Unfortunately, the patient we are about to discuss died on the 13th of May in 2026. However, we do have consent from his wife to continue to demonstrate this story and his journey through our service. Sorry, I can't see what's back. Okay. So the background to the Wellness Service. In 2023, Dr. Pat Haslam and Jamie Sweet reviewed 835 people who had 3 or more unplanned admissions into Furness General. They found that these patients accounted for 11% of patients admitted to Furness General, 28% of unplanned admissions, and 31% of bed days. 50% of these patients were readmitted within 4 weeks of discharge, and 75% were readmitted within 8 weeks. These patients were found to have multiple long-term conditions, disjointed care across several services, a chaotic or cluttered home environment, poor mobility, polypharmacy. Initially, these people were quite independent, a lot of them, but became more and more dependent on care as their multiple admissions clocked up. They were socially isolated and obviously had high tendencies to Furness General ED. The concept of the Wellness Centre, as it was first known, developed a pilot study which began in 2024. This looked at the holistic management of patients, complex case management, and opportunities for earlier intervention. The Wellness Service, as we are now known, came into its current format in July 2025. So we've just been going for a year. And we currently see patients in the deterioration phase on this screen. The diagram of this diagram, but in phase 2 of our development, we recognise that there is going to be the opportunity to support and intervene in the recovery phase for these patients. Next slide, please.
Yeah.
So the service, as we currently are, we see patients on Walney Island, Barrow or Dalton, and these patients must be registered with a GP at Walney, Barrow or Dalton. Patients are discharged from Furness General after 3 or more emergency admissions in 12 months or after a long length of stay of 14 days or more. We aim to see these patients within 40 weeks of discharge. We support people to live well with their existing conditions, providing coordinated, holistic, intensive early interventions and care. Can I have the next slide, please? We use a dashboard specifically designed to identify patients who meet our criteria. We have twice weekly MDTs discussing different patients at these MDTs, and the MDTs include the clinical lead, advanced clinical practitioners, the case managers, pharmacists, pharmacy technicians, healthcare assistants, patient navigator, adult social care, therapy team, and our third sector partners. Referrals are also accepted from health professionals who have identified people at risk of readmission. Next slide, please. So today we've brought Mr. Charlie as an example of a patient journey within the service. So we met Mr. Charlie quite some time ago, it feels now.
It does not time ago.
But I'm just going to provide a little bit of background about him, and then Lucy's going to talk a little bit more about what we did for him. So he lived with multiple long-term conditions. In March 2024, he was seen by his GP for exacerbation of COPD. He saw his GP again in May 24 with leg swelling and feeling unwell. At this time, he also had his first emergency admission into Furness General for 3 days with anemia, an acute kidney injury and uncontrolled type 2 diabetes. He was seen again by his GP in November 24 and had a second emergency admission for 14 days with symptomatic anemia and worsening shortness of breath. He was diagnosed with heart failure at this time. Hospital admission 3 was in January 2025 with shortness of breath, worsening heart failure, and at this time he was referred to the heart failure team and the community therapy for physio via Furness General. He was admitted for the 4th time in February 2025 for shortness of breath and chest pain. And in June 25, Mr. Charlie was admitted for a 5th time again with shortness of breath and heart failure symptoms. He was identified then to us via our dashboard and consented to being admitted onto the wellness service caseload. And I'll now hand over to Lucy, who'll then what support and care was provided for him.
Am I okay to just stand up so I can see the screen? Is that okay? Just to make it a bit easier. So as Sally said, I was Mr. Charlie's case manager, nurse by trade. So just to recap, Mr. Charlie lived with his wife. She was his main carer. There was no formal care package in place. They lived in a council flat, a ground floor council flat, and he was mainly housebound. So following his identification from the dashboard from the wellness service, we were able to piece together 4 key proposals and outcomes for Mr. Charlie, looking holistically at his care. So first of all, probably the most important thing was to reduce his recurrent hospital admissions. As Sally previously noted, he had 13 comorbidities, which is a lot, making him very susceptible to recurrent exacerbations at any given time. And obviously this increased the repeated hospital admissions and highlights the importance of proactive and reactive management, which I feel we demonstrated with the wellness service. We also wanted to focus on integrated care, looking at everybody working in collaboration for Mr. Charlie and to actually bridge that gap between hospital and home, because we know historically that patients, when they're in hospital, they get so much thrown at them, and then when they go home they feel like they're on their own. So that was really important to us. Mr. Charlie and his wife reported feeling overwhelmed every time they were discharged from hospital. He had a new chronic issue, very little follow-ups within the community. So it was about that, really, about making sure we could better control and provide closer monitoring of his long-term health conditions. And lastly, to
to provide a holistic approach to his needs. So when we're talking about holism, we're not just talking about physical needs, we're talking about emotional, social, psychological, and obviously it was really, really important to him to live well and stay at home. He was a massive family man. Next slide, please. So we're just going to look into Mr. Charlie's journey in more depth, specifically from a case management side. So as Sally said, he was identified by the Wellness Service back in 2005 in June. An initial consent call was made to introduce the service. A lot of people hadn't heard of our service at that point, and to gain consent to engage. I find personally that that initial phone call, you can get a lot from that phone call. You can get mixed emotions, you can get anger, you can get relief. A lot of patients report like it's an extra lifeline. You're ringing them saying, hello, you know, we know you've been in hospital, you know, we'd like to come out, we'd like to listen to you, do a home assessment. Is there anything you're worried about? And can get a lot. You can gauge the patient experience from that point, which I think is really, really important. He was then assigned a designated case manager, which was myself. We arranged an initial home assessment. We went out to the house, encouraged the family to be there, and kind of identified the possible reasons to why he was so frequently admitted in and out of hospital within a short period of time. So we're kind of looking at what's going wrong, where is it going wrong, and how we can prevent this really. It was reported by Mr. Charlie and his wife that despite living with these complex long-term health conditions, he rarely received any community follow-ups. He had COPD, so he had very little symptom management. We found that he was overusing his inhalers, and he needed symptom control for shortness of breath, which was supported by our wellness clinicians and our pharmacy service, which is also involved in the wellness service. Frequent admissions were for heart failure. Although he was referred to the heart failure service on his last admission, we were managed to expedite that referral. We identified that he was overusing his GTN and that he needed his medication and the review of his needs optimised, collaborating with those services, heart failure specialists, making sure that we were supporting with venipuncture, fluid restrictions and his diuretics, things that are really important for monitoring people with heart failure. We also identified that he was frail and living at home. He'd had some recurrent falls. We were able to expedite assessments through occupational therapy and community physio, applying essential equipment to help him live well and at home. We monitored his BP. We provided him with a wheelchair, which was really important for Stephen, Mr. Charlie, because he was a very sociable guy. He still loved going out with his wife to the bingo, having a pint, you know, and that's something that he still wanted to do. That was something that was really important to him. And I think that is really important that we try to sort of uphold that really. And lastly, his diabetes, which was really, really important. He had really poor control, erratic blood glucose measurements. He was always drinking a bottle of Coke. Wife didn't know how to support him with his dietary intake. And a key thing happened that during one of the routine assessments, our wellness pharmacy tech discovered that his wife was actually still administering his subcutaneous insulin, and it had actually been what's the word? Discontinued at the December before. So yeah, actually shouldn't have been on the medication, and he was still allowed to get it provided by the GP as well, which so pharmacy promptly escalated it, and that was all sorted. So you can see from Mr. Charlie's MDT journey, he had lots and lots of people involved. These were all referrals that we can do as part of our case management. Age UK was a really, really big one. They worked really well with Stephen and his wife, looking at benefits, because she was his main carer. She was entitled to a lot of benefits, and they were able to reclaim council tax and provide hand-in-hand services. Adult social care referrals, massive input with regards to not only like patient act assessment, but carers assessments, making sure the pendant alarm was still in so that his wife could still go to her appointments, go shopping, still have her life. St Mary's Hospice was also a big part. They provide compassionate community groups. There was the option of a virtual ward, even though he wasn't ever admitted to a virtual ward, it was still in the back of our minds that if we felt he needed to be stepped up for more regular observations and things like that, he did not want to go back into hospital, so it was crucial to keep him at home. So that was always in the back of our mind. Ongoing community therapy, like I said, he was deteriorating at home, just a progression of his disease processes really, but making sure that that therapy, physio and OT, was still linked in all the way through his journey, not just at the start, right the way through. We devised an emergency healthcare plan for Mr. Charnley with his specialist teams to look at streamlined pathways so he could get the services he needed without having to go into hospital and have a long length of stay. Towards the end of his life, we looked at referring on for end of life care planning, which we identified a long time ago because he actually had 12 weeks palliative care at home, but after that he still kept going. He had a great quality of life, but yeah, he had support from the hospice, which provided 4 times a day care, which was massive for his wife Pauline, took that burden of responsibility off her, and he was able to have that care at home, which was really important. And lastly, the bread and butter of all nursing in the community, the district nurses were able to go out and support with not only pressure area care, with making sure he had the just in case drugs, which is some drugs that patients have when they're entering like the last days of their life, making sure ensuring a good death really. I know we don't like to talk about death a lot, but a good death is pain free and you know that type of thing really. And just to wrap it up, so Mr. Charlie, I believe, was with us maybe 8 months, a long time, and he had no hospital admissions, 0 bed days and 0 ED attendances, which just speaks for itself, doesn't it really? And the amount of you know, work from all the teams, it was a real team effort, it was brilliant. And Pauline, his wife, Pauline Charnley, is on the next slide. She's just summed up a little bit about how she felt we helped her and Stephen. Thank you.
Thank you for I thank you for round of applause.
Thank you.
Questions? Tony, do you want to kick us off?
Yeah, can I say thank you? That was absolutely, you did a cracking job, but more importantly, the impact and the change you made for Stephen's hands like is first class. So I've got just 2 simple questions. So I'll say them and then you can answer accordingly. One is if you had if what would make a difference in terms of making this service even more holistic? You could say, that's my first question. And then the second one is, great to see the data there, because this is the way going forward as part of the solution to the NHS plan. Have you got data across the piece? Because there's some big issues here in terms of readmissions, reduction in bed days, etc., because that makes a case for saying we can change things in this organisation across the North West. So 2 questions: what would you have, magic wands, and what's the impact?
So I think if I had a magic wand, it would be so great to be able to access adult social care's records.
Yeah.
We've just talked about that on the way up.
Yeah.
It's so tricky. They do attend our MDTs, and so we do have that link with them, which is massive. But a lot of these patients are requiring Care Act assessments, carers input, so it is massive. Have you got a magic wand?
I think that would be my magic wand. Yeah, absolutely. It's just vital, isn't it? But it would be so much easier if we could access it
There and then,
there and then.
anytime.
Yeah.
Or be able to add to their records. Yeah, and I think data-wise, obviously we've been conscious about data. We've worked quite closely with the BI team from the trust, and I think what has kind of clinched it from my point of view is that we've got actual patient data, so we've got sort of patient outcome measures, and they're probably the things that are better for us to see, if you will, as a team, because you can see how you're making a difference to your patient.
Thank you again.
Lou.
Hey, I'm Lou. I'm the Director of Comms and Engagement for the Trust. I've just got a point and then a question, if that's all right. So the point, because I'm not sure if you know this, but on all the board, but we've got on Sunday it's the NHS's 78th birthday, and they always do a national campaign. And this year it's about the best of the NHS, and the service is actually being held as one of the case studies of this. So it's going here, so I will share it with you. So it's in the communications toolkit that was shared with us yesterday, so it will be shared across the country. So it was just to make everyone aware, and that's just an absolutely amazing achievement. And then my question is, what's next? Like what do we, and I appreciate you're a very small team.
Yeah.
Make us bigger.
Well, you're in the best of the NHS now, so.
Can I make a comment on what's next? So we want to expand the service general, obviously to replicate the Lancaster patch, recognising the impact that you've had on the patients so far, and it's a key piece of our reducing days work from home. So.
And I think obviously we're kind of finding our patients a little bit with the dashboard at the minute, and we're hoping that we'll be able to take more referrals from, from GPs, from the UCR. Yeah. So that's where we envisage it going, but we've just got to have the capacity in the caseload to be able to, because we don't want to be offline. So it's about managing that process.
Well done.
Nicola.
Yeah, thank you. Well done. And I could see you were quite nervous. I thought it was an
No,
amazing
I was.
presentation. So you did amazingly well. It really touched me because I've been responsible for caring for elderly relatives, and I know how incredibly difficult it is for people to navigate our system. I find it difficult, and I know the system. So people like Pauline's words were really important for us to hear, and I think that national reputation. I certainly had heard about your service sitting on a board in part of the region because of how well people are getting to know what you're doing, and I think the more we can support you being able to share the learning without having to distract from the service, the better. You talked a lot about the partners that you were working with, and I suppose what I'm interested in is how responsive have they been, or how much have we had to really work on that? Is there things that we can do to further those relationships with those partners? And are there partners that you would love to work with that you haven't had that opportunity to work with yet?
I think everybody's been really receptive. I think because it's a new service, people have wanted to be part of it. We do, people come to the MDT that if there's a patient that's relevant as well. I think probably that wasn't recognised in that story, that St Mary's Hospice can join if the patient's relevant at that time. And I think everybody was really on board. Maybe there would scope for more third sector, because at the minute it's only Age UK that we have come, but they've been very supportive.
Good.
And they are very good. My experience of them personally is that they're very good. But
Yeah.
I think yes,
And
and how you can work with other
Yeah.
sectors.
I think the majority of patients get a referral to it.
They do, yeah.
Because they do so much.
They do, it's a really valuable service.
Amazing. Thank you.
Sarah.
Yeah, thank you. Hi there, I'm Sarah, I'm one of the non-executive directors and I chair our quality assurance committee as well for the trust. So I think first of all, just to echo what everyone said, I've heard about the wellness service actually from other people outside the organisation and how good it is and what a difference it's making. So it's really great as well to come for you to be here today to tell us about it and the impact it's having. So that's really good. Two things jumped out for me, which they're probably not necessarily questions for you, but I think they're questions we need to think about for all patients actually. So the first one was your comment, Lucy, actually about the family being discharged from hospital with some paperwork, knowing they've got a diagnosis, which is that unfortunately at some point Mr. Charlie was going to die, but not really knowing what to do or where to go or where they could get support. And that's not unique to this situation. It's not unique to our trust either, actually. I've heard about that in other places. So I think my first question towards actually as a trust is how can we support, how can we work with our clinicians and our teams to ensure that everyone who leaves hospital does have some information about where they can get support, and then where relevant, obviously they might get picked up through the wellness service. So I think that's the first thing we need to think about and seek some assurance around. And then the second thing for me was that focus you had as well around Mr. Charlie's preferred place of dying as well, and that he be supported at home. And I won't ask for the detail. I mean, I hope that we were able to support that final wish as well, which is really good. But one of the things we're putting some more focus on is actually how we support patients and their families at end of life, and how we ensure that we know what their wishes are and we can support them as best as we can to have those. And we're doing a piece of work around that at the moment. So I think what I'd ask is that we have to think about that as well in the context of both wellness service, so the wider end of life work that's going on. So, but thank you for everything that you're doing, and it just makes such a difference. And obviously, it's also makes a difference to the trust as well, and to the service we're able to offer to other patients as well as for those individual families.
Karen.
Oh, thank you. And thank you for that presentation. My name is Karen Deeney and I chair the People Committee. And I was really struck today in your presentation as members of the team, your sense of pride and joy in being able to deliver such a service really came across. And I just wondered, firstly, whether you could tell us a little bit more about that, because in times when things are really challenging for our members of staff, it's great to hear such a positive tone in your voices about what you're able to do. I'd love to hear some more about that from your perspective, how it feels for you as members of a team able to do such a great job. And then secondly, on from that, is there something you think we could learn and we could spread more of, so that more of our members of staff feel the way you do about your service?
Where do I'm really passionate about it. I mean, I've been qualified for nearly 22 years, and this is my first Band 6 role, my first role in community. But I have worked in other places throughout the hospital, and I've seen discharges and I've seen recurring admissions, and I'm really, really passionate. And I think with case management, because we can zone in and focus on this family, you build up this relationship with them, and you actually think, you know, if it was your family, how would you like them to be treated, and the relationship you build with them, the feedback. When we first looked at Mr. Charnley, we were so proud of it because we lived and breathed him for such a long time. But actually, this isn't. This is like daily now. These are all our patients, aren't they?
Yeah, we felt like there was better patients to bring.
Yeah, there's every day there's a new thing to shout about, and I do think that the team's been selected brilliantly because we're all so passionate, but we all bring something a little bit different, some experience, and sometimes it's personal experience as well. like for instance, this lady said about experience being a carer herself and trying to navigate services in the community. So yeah, I think we just love it, don't we? We just see
You
what
can see how you help
Yeah.
the patient.
and you can't just look at the facts and the figures. You've got to be there and be living and breathing it, and that to me makes a whole difference.
And I think maybe unfortunately for some other teams, we maybe do have a little bit of a luxury of having a little bit of time to spend with
We
the
do.
patients, and that's what they relish.
Yeah.
And having a point of contact.
Yeah.
You know.
Yeah, we do get loads of calls, loads of emails. Yeah, and we're there Monday to Friday, and yeah, we're a lifeline.
I'm going to bring our chief executive.
Yeah, thank you. Wow, a couple of things. I think firstly, I'd want to say thank you to Charlie, Pauline. What a brave and lovely thing to do, to be able to let us have that experience to bring to life what's a fantastic service. So thank you firstly to Pauline. That's very kind. At a time that you shared us so much grief. To share that is very, very good. Thank you. And then I've had the opportunity to spend a little bit of time with the Integrated Wellness Service. And also spend time with Pat as well. I don't think we should acknowledge what an outstanding service that you provide, the impact it has on individual patients and families, outstanding, and the impact that has on reducing some of the pressures in our acute and community services, and probably reducing some of the pressures in primary care and in adult social care as well is incredible. So the impact individually, impact organisation is really important, and those things mean we're better able to care for other conditions. So thank you to all of you. Thank you to the team. And to me, it's such a powerful example of neighbourhood care. So that is one of the key NHS 10-year plan priorities. I struggle to describe really clearly what that is in what you've just set out very, very clearly what that looks like. So when Lynn was talking about one of the next steps being the potential to expand this into parts of Morecambe, that's a fantastic thing for us to be able to take. So thank you so much. It's a privilege for us as a board to hear these stories.
Can I just say one thing, sorry, just from my perspective? So I've only been matron of the wellness service for the last 3 months, so I'm still very much learning the service as well. But I do want to just reiterate that Mr. Channel is just one of very, very many. It's an everyday thing that jumps out at me. But also I think we need to be doing some more work looking at linking with virtual wards who also sit under me. So for example, when you look at that roadmap of the prior to admission, previous admissions, none of those needed to have happened. Everything that he was admitted with, we can treat in the community. We are doing with our IV furosemide and iron infusions and all that sort of thing. So I can envisage him as a patient stepping up and down between those community services, not needing to hit the patient services. So the way we can all work together moving forward would be great.
Very good. Briefly, Sarah, and then Nettie.
Yeah, thank you. Actually, it partly relates to the virtual ward point, I think, actually, but it struck me just when you were talking about it's a Monday to Friday service. So it just actually in terms of assurance. So if then one of your families was in distress over the weekend, how is that supported and managed so that they don't then become another emergency?
Yeah, so obviously with safety netting, knowing, I mean, they're aware from the start that our services are Monday, Friday, 9 to 5. So we are safety netting. We do quite routinely, it feels at the minute, step up to virtual ward. And that does seem to be happening in the latter part of the week when we know that we're not going to have that service at the weekend, that we are stepping patients up because we've got concerns. So I think our clinicians are always kind of aware of who we've got. These patients, you kind of think they're not going to be that dependent, but they end up being quite brittle and they're having, they are quite sick, a lot of them. So yeah, we've got an oversight of patients.
Thank you.
I'm going to raise a question, but I'm not actually expecting you to answer it. It's more a question for the board more broadly. Because as a non-executive director, I also have oversight around digital data and technology. And I think you mentioned about records, you'd be able to see you're very clear on you're there to serve the whole person and their family. And I think if things are still a bit siloed, what could we do with the technology so things could be more joined up, and so that you could also use that to help you with your interactions in terms of giving family support and guidance. And I'd encourage you, if you don't have the answer now, to give that back to the organisation so that it becomes very clear in our digital ambitions.
Thank you. On behalf of the board, thank you for taking time out to come along and echo what Steve and others have said, but thank you for all that you do for people who live in this area.
Yeah.
Thank you for your time.
Thank you.
Thanks.
Also, it is, I think,
So we now turn to item 22, my report. So I'll take my report as read, but I'd just like to draw out one thing. I'd like to congratulate non-executive directors Amin Kamaluddin and Sarah Rees on their reappointment by the Cardiff to continue serving on the board. And I'd also like to congratulate non-executive director Dr. Karen Deeney on her appointment as a visiting professor at the University of Cumbria. Congratulations, Professor Deeney. Are there any questions on my report? No. If not, we will move on to item 23, the Chief Exec's report. Steve.
Yeah, thank you, Andrew. What I'd like to do is take the report as read and use the bulk of the time on the agenda under this item to brief board members on the National Maternity and Neonatal Investigation Report published yesterday. You'll see in my report that paragraph 40 and onwards refers to that. Of course, at the time the board papers being issued, the investigation report had not at that time been published. As everybody will be aware, that was published yesterday following the separate publication of the Ockenden Maternity Review into Nottingham University Hospital and NHS Trust a week before. So I'd like to start as Chief Executive of University Hospitals in Morecambe Bay NHS Foundation Trust by acknowledging the trauma, the loss and the grief that mums, children and families across our region will hold forever as a result of previous failures in maternity care. To Trust, as an NHS and as a board, we're deeply sorry for those failures. And we recognise that nothing we can say or do will change what's happened in the past. But as a board, we are absolutely determined to do everything we can to ensure that going forward we learn, we listen, we hear, we act transparently, and we continue on our journey of improvement in maternity and neonatal care. I think every one of us would realise the significance and the importance of Baroness Amos's investigation. The report was published in full yesterday, and that includes the individual reports from the 12 trusts, which were the trusts which formed the National Maternity and Neonatal Investigation. So that information is now widely available to all colleagues. The opportunity for us is to identify the learnings from our own review and also to identify the learnings from other trusts' reviews. And in doing that, to identify the learnings in those other documents, the Nottingham University Hospitals Ockenden Maternity Review, the Shrewsbury and Telford Hospital Review, so we can be absolutely sure that we're taking every possible action to ensure that our services are safe. We do know as a trust that we've made significant improvements over the last years, and we continue to do that. It was positive to see the CQC assessment of maternity services at all 3 of our sites last year being assessed by the Care Quality Commission as good. It was very positive to see the development, expansion and support of services such as our maternity triage service, which was able to open in a new facility earlier on this year, providing 24/7 access for mums across our region to specialist midwife advice, guidance and immediate triage. And also very positive to see the investment this trust has made in supporting services such as bereavement support services. All of those are important. All of those are based on feedback that we've had from mums and families, but we know we have more to do to improve. Only yesterday, one of our MPs raised that they met with two very brave parents who lost their baby daughter last year, and they still feel that they don't have all of the answers and they are struggling to get understanding, clarity and information from our trust. I know from the conversations I've had with all of our board members that every one of us is determined to ensure that we act transparently, we act openly. Where things do go wrong, we recognise that, we say that, and we learn and do that with the best endeavours to improve services going forward. So we must recognise the report which was published yesterday and those other reports which have been published earlier as a key turning point in the NHS nationally and as part of our improvement journey going forward. And for those reasons, Andrew, I wanted to really use all of the time available in this part of the agenda on those aspects rather than necessarily the content of the rest of the report, which I would like to put forward for noting with the board. Yesterday, NHS England called chief executives, chief medical officers and chief nursing officers together in London to give an opportunity nationally to take stock of that application and to be clear on the steps that we now need to take going forward. So I was at that event, as was Helen, our chief medical officer, and Lynn, our chief nursing officer. What I'd like to do before we go to questions, discussions and challenge from our board members is ask Helen and Lynn to summarise the key things that we heard yesterday and the key content of the reports that have been published. So if I can go to Helen first.
Thank you, Steve. So just going to cover, first of all, around the National Maternity and Neonatal Investigation led by Baroness Amos. And I will touch on the elements that will then go into what Lynn is going to cover, which is the what we heard about yesterday, which is the 100-day sprint and looking at a 10-point plan to continue to improve services and continue to make things safer. So covering the 8 recommendations from Baroness Amos's report, these cover a number of timeframes and also a number of organisations, but I'll touch on some of the things that we've already started to think about and the things that particularly link in to the 10-point plan. So the first of the recommendations was around creating a maternity and neonatal commissioner. The second, really important, around listening to the voices of women, birthing people and families, and we'll touch on some of the things that we'll be looking at as part of that in the 100-day sprint. The third was what you've just touched on there around the quality, transparency and oversight and accountability of investigations, and ensure learning is captured and acted on when things go wrong. And there's a number of things that we are going to be looking at, particularly around things such as subject matter experts, thinking about how we manage incidents so that can be done in a really timely way and having the right people there. The fourth is around designing a modern service framework, and that's for maternity and neonatal services, but there's a number of things there that again you've touched on in terms of triage, and we'll expand on that in terms of where we are and what we need to do, but also around critical senior decision making 24 hours a day, particularly around obstetric consultants and anaesthetists, and initially complying with the Royal College, but certainly looking further forward what that needs to look like. Recommendation 5 was around treating racism, discrimination and inequality as critical maternity safety issues, and those include some immediate actions to collect, analyse and act on the most granular data that we have, allowing us to identify inequities and target service improvement. And again, that's an area that we feel that we really need to concentrate on, and we'll touch on that in the 100 days. The 6th recommendation was around clarifying existing system governance, oversight and accountability structures. The 7th was work being done at national level around colleges, universities, postgraduate education. But that does touch on a number of things to do with culture, team working, strengthening leadership. And some of the things to do with that is that very much that joint medical and nursing involvement in this. And that was certainly what we saw in that meeting, with the presentation being jointly presented by the National Chief Nurse and National Chief Medic. And really importantly, we think how we move forward, how we have things reported to this board, and who's represented, to make sure we've got that medical and nursing leadership, which we have in this organisation, obviously with our Director of Midwifery and also our Divisional Chief Medical Officer for Obstetrics and Gynecology. And we may need to think about how those two individuals report through to our board. And then the eighth recommendation around estates and digital systems being fit for modern maternity and neonatal care. Now, not just this investigation, but we've also received information that we need to be following around, as you mentioned, the Ockenden Nottingham investigation around post-death care processes. And so following on from obviously the Fuller inquiry and recommendations that came out of that, we'll also be looking at needing to provide a board assurance frame, board assurance statement, and also a forthcoming audit looking at compliance with the Human Tissue Authority, making sure that we are providing care. So I'm just going to hand over to Lynn, our Chief Nurse, to go through the 100-day sprint and how that interacts with what we've just gone through.
Thank you, Helen. So I'm going to take you through the 10 points around the 100-day maternity neonatal sprint and the urgent actions required from Trust. And the purpose of this is to have a national movement to improve maternity care and not just rely on local improvements. So the first one is around listening to women and their families by rolling out Martha's Rule. We already have Martha's Rule for the general patients, and we're poised now to roll that out in maternity. We've already been doing some work around that, so we're confident that that will happen very quickly. The second action is to listen to women and their families with real-time and transparency, particularly around patient-reported outcomes and experience, and to review our clinical audit outcomes and the data, and that's acted on at board level. So there's very clear requirements about boards being cited on what's happening in maternity care. The third is that there is dual board level accountability from the Chief Nursing Officer and the Chief Medical Officer for maternity and neonatal care. I think that's demonstrated today by Helen and my own approach. The fourth action is an AMOS interaction staff listening exercise, and there will be more detail of that coming forward, but very much linked with the freedom to speak up guardians and making sure that maternity and neonatal staff have the opportunity to speak up. 5 is addressing inequalities in maternity and neonatal outcomes, but particularly Sue will remind us about what that feels like for women coming through our services. We've talked to Chris Chiswell, who will help us to sort of look at our inequalities in that service. Number 6 is ensuring 24 hours, 7-day safety and responsiveness of maternity and neonatal services. Number 7, Trust to review their home birth services to make sure that we've got good processes in place. One of the key things that came out yesterday was the challenge for midwives in supporting women's choice in home birth, but actually who choose to work outside of guidance. So there's an ask gone back to the national team to provide some support for midwives around that. The number 8 is about responding to patient safety incidents, complaints and concern with humanity, candour, and through a trauma-informed approach. We currently in the Trust have an exec review group where all our clinical incidents are reported, reviewed and scrutinised. And our maternity and neonatal incidents go through that general approach. The key thing that we've been challenged is that we need expertise in reviewing those incidents and complaints. So we are proposing setting up a separate exec review group, particularly around maternity and neonatal incidents. Deliver safe and effective triage in maternity services, and that should be evaluated. And I also might want to say a little bit more about our triage services, but that is audited at 3 months. And that's a board level audit. And then the 10th point is around post death care, which has come out as a key theme, which Helen has already referred to. So that's the 10 actions. So I'm happy to take.
Thank you, Lynn. Thank you, Helen. And as both Lynn and Helen have mentioned, we're joined also by Susan Foyle, our Director of Midwifery, has personally made significant transformation and improvements in our maternity services. So I think we're joining the board as well for this discussion, Susan. I'm keen that we create as much time as we can for any questions and challenge from our board members. Perhaps Susan can ask you just to briefly summarise current triage service and then what we're expecting in terms of that review over the next 3 months.
Thank you, Steve. So we have moved to a 24-hour dedicated triage line, which is hosted in the new triage unit at RLI. And we have dedicated midwives with no other responsibilities other than to answer the phone, and they organise any admission that needs to be organised across the bay. So although all calls come into RLI, the admission is arranged, and the records are then shared across the bay as well. So it's really clear why the woman's come in, what grade of triage she is, how quickly she needs to be seen. And so women can access that at any time of the day or night. And we're seeing some good results already. Since it's been opened in April, we've seen double the number of admissions from that triage, which tells me that there's we've improved on the variation of advice that women are getting. It's more consistent now. So I think that has started to yield some positive results. We're just waiting for the service specification to come from NHS England so that we know what we're auditing against, and then we can get on and do the audit. Thank you, Steve.
Thank you, Steve. Very important report. We're turning to questions. Mike.
Thank you, Chair. Lynn, in the 100-day sprint, the things that are in there, things like Martha's Rule, do they have to be completed within that 100 days and up and running, or do they have to be in trade?
We didn't get much detail on that, Mike, but we'd already, before yesterday, made moves to implement Martha's Rule in maternity, irrespective of the reports. So we've got a really successful Martha's Rule lead who's been really effective in rolling that out in the general areas, and then the next step is maternity and paediatrics, so we're already there.
Yes.
And the thing about the item around mothers who want to give birth outside of national guidance, have NHS England given a timeframe commitment when they're going to come back with?
So we were asked to take the recommendations and report the 10 actions, and then report back to the team about things that there's a lot of midwives in the room and CMOs around what the challenges are and what we would need help with. So that was one of the key things that came out. And I don't know whether Sue wants to mention about that, because it is a challenge about people's choices, but keeping midwives safe.
Thanks, Lynn. It's actually not just a challenge for midwives, it's an obstetric challenge as well. And some of our obstetricians have felt very vulnerable over the past couple of weeks with a couple of cases. I've already started to look at how we do a co-designed piece of work with our service users around a better process for when women choose to birth outside of guidance, because it might not just be home birth, it might be that they're choosing to birth in hospital but outside of guidance as well. So we're just looking at what the needs are, and definitely to do that co-design piece of work. Thank you.
Sarah.
Yeah, thank you. I agree, it's a really important thing that we need to review and discuss as a board, and especially because for Morecambe Bay, we have a history, unfortunately, of not having provided good care and experience for our problems at baby, so I really welcome the discussion. A couple of things I think I just wanted to pick up. I suppose so maternity before it comes to board, maternity before it comes to quality assurance committee. So it would be really helpful, I think, at the next quality assurance committee to have an interim update on progress against the action. So I think that was the first thing I was going to suggest, and I recognise that a number of those things, for example, mortuary care, if you like, features in other reports we receive at Quality Assurance Committee as well, so it sort of covers a number of areas. On the equity of outcomes and experience for moms and carers, we have a plan to receive a report which would look at the sort of annual experience, if you like, because we know our numbers are quite low and therefore we can't do it in an anonymous way on anything less in terms of time period. We haven't had one of those yet to Quality Assurance Committee, and I think it would be timely now for us to bring that forward. So if I don't know if we can have it in time for August, but I do think we should be looking at bringing it as soon as we can, because it's actually, I think, starting to be a bit overdue to have that conversation. And then the other thing I just wanted to pull out was, I know we've got a number of initiatives in place, and it speaks a little bit to, I think, some of Steve's comments in your introduction, Steve. So we know as a trust, we haven't done this well in the past, and we've been improving, and it's reassuring to have the external validation of that. But you've given an example today where, unfortunately, we still have cases where we don't always get it right, and we still need to continue to improve. So I think to help us be assured about the impact of the processes that we're improving and the changes that we're making, when we capture the initiatives that we have in place, if we could try to be quite time specific about when those initiatives are being brought in, when we expect them to bring an impact, and so that we can try and monitor how that might be improving, hopefully, outcomes and experience for mums and families. I think that'd be really helpful. It would help us, I think, particularly moving from where we know, there are more historic cases, but actually also understanding if things are persisting since we've had new initiatives in place, if that makes sense. Thank you.
Yeah, that's really helpful. And we must do it for the reasons that you said. Baroness Amos' report also is explicit about this and states that trusts must take immediate action to collect, analyse and act on the most granular data this systems allow, and use that to identify inequities and access experience, safety and outcomes. So your challenge about not waiting for an annual or longer timeline report is really important for us. So I think we should take that as an action through Lynn and Sue to be able to provide that level of detail as the
Karen.
Oh, thank you. I had a few short questions. Sarah's asked one of them, so that's really helpful. Just three brief ones. The first, I completely understand the 10 points that you've articulated. My question is there anything that we feel amongst those 10 that for Morecambe Bay is missing? Is there anything that we would have expected to have been there and it's not in the 10? It's just very easy sometimes with the external regulation, pressure and oversight to focus on what we're asked to do and perhaps just lose focus on something local. So first question, is there anything missing from the 10 for us that we need to consider additionally? The second one is in connection with triage, and that's fantastic, Sue, to hear about that 24/7 service, but actually, are we collecting population health data and thinking about inequalities with access to triage, and have we got effective, appropriate, timely translation services? I know in the past that's been a challenge for us. And the third question is, we know, albeit we've had a much more positive CQC report for maternity services, are maternity services staff colleagues have been under pressure and scrutiny for a very long time. And so with the work that this really important and critical programme of work, the sprint you've described, how are we going to ensure that our staff are really effectively supported for this new sprint for them? So 3 different questions, but yeah, thank you.
So I am going to ask Sue to come in, but anything missing? I think your 3rd question probably sort of highlighted around what support for our midwives. Certainly from a Morecambe Bay perspective, and like 11 years and a lot of scrutiny, you know, quite rightly. But how do we support midwives and to keep the positivity that has sort of developed over the last year in maternity. And I'm going to ask Sue to come in and talk about some of the leadership development staff support work that she's done, which has made a massive difference to maternity services, maternity obstetric neonatal services, which was highlighted in the CQC report, particularly around changing culture. And then in the AMOS report, our local AMOS report, really highlighted that there had been a difference in leadership over the last few months, and that had made a big difference to staff health and wellbeing and culture. So I'm going to bring Susan in because I think she could probably answer that better than me.
Susan.
Thank you. Yes, so we've done a lot to wrap around our staff. So ever since this investigation started, I've done monthly all teams briefings with our staff to check in with them. And we've had 50, 60, 70 people on the call each time. It's been really well attended. And I've just done one today, actually, at noon. I did an all teams briefing. We had 65 people on the call, not just midwives and obstetricians, because I think, you know, we all talk about midwives, but actually it's obstetricians that have been under scrutiny as well. It's the whole multidisciplinary team. So we've wrapped around everybody today. I think that there's been a number of emotional triggers in the report for people, and that, you know, I'm not going to sit here and tell you that people aren't struggling, because some people are. And we've put in place the PMA. We've mobilised PMAs to support them. We've got heads of midwifery on each site, so the main sites, so RLI and Barrow, over the next couple of days. We have told everybody occupational health is available and they can contact us personally. But actually, once I'd gone through the report and talked to them about, you know, the transformation that we've been through was actually acknowledged. We still, however, have work to do, and we still don't get it right for some of our women, and we need to change that. And that was it was received in a very professional way, and I think their resolve to get it right is still there. So I think that, you know, once they get over the initial emotional, I think it's just opened up some wounds again. Obviously it has, but once they get over that, I think that they'll do what they've always done, and they'll rally round, and it will galvanise their resolve to get this job done, and to really get it right for our women. And I didn't see any waning in that today at all on the briefing. In terms of, in terms of the leadership programme, we'll have 50 nurses and midwives will have gone through that by the end of November.
Okay, thank you. And there's just my question about translation and triage.
Yes, so with the triage, no, we don't monitor ethnicity in triage. We monitor it for clinical incidents and when things go wrong. And I think that there's more work to do there.
Thank you, Susan. Sorry for interrupting you prematurely. Steve wanted to add something.
I thought it was a really helpful question, Karen, and just to ask my colleagues, Susan, Helen and Lynn, whether we've got mechanisms where we can ask that back to mums and to staff. We absolutely must deliver the national improvement plan. That's essential. We don't have a view, and is there anything which is missing in respect of Morecambe Bay? But I think that could be very powerful through our Maternity Voices Partnership and through our clinical staff groups, so that we can be assured there isn't anything extra or if there is, we can be absolutely clear about how we take that forward.
Yeah. Nicola.
Yeah, thank you, Chair. A couple of points, 3 points, but one is actually an extension of both what Sarah and Karen raised. The first one is you talked about the links to the Freedom to Speak Up, and I know that is on the agenda, so I would really welcome us just drawing out where we think some of the points we've already raised in that will also help with some of the points that we've raised here today. The second is around obviously our utilisation of technology and it being appropriate and the right fit. And I'm conscious that we already have Badgernet and we use that, and that there is a consideration that we may review what system we use when we go for a one system electronic patient record system, but that is still to progress. And in the meantime, we are where we are. So are there gaps in functionality that we want to close, and how might we close them? And is there opportunity in terms of some of the missing data and our understanding around inequalities and health inequalities? There is additional functionality where we can collect more information about, particularly I'm thinking about patients' experiences as well as their outcomes. I'm going to ask Sue just to respond, particularly around the Badgernet, because I'm not close enough to that to. That's the case.
Susan.
Yeah, look, I think that there's a lot more information we need to collect about women from different ethnic backgrounds, and also that your point about experience is absolutely key. It's all right collecting outcomes, but experience is equally important. So I think that some sort of patient-reported experience measures is extremely important. In terms of the data, the outcome data we collect, I think we need to go further. I just think that there's so much more that we need to do. Chris actually emailed me this morning around looking at a different way of collecting that data. So we'll have a look at that. We've not got this right yet, I don't think.
So I look forward to knowing what that will do and what the timescales around that would be.
Yeah. I don't know the answer to that at the moment, and that what I'd like to do is to work with LMMVP to have a look at what that should look like, because I think asking that question of them will give a different perspective to what we think we need to collect. So I actually can't give an answer to that at the moment.
Helen.
And we've been looking at ethnicity recording and an action plan around that, which I know is due. The plan is that that will be coming to one of the quality assurance committees, because our public health consultant, Dr. Chris Chiswell, has been leading that programme. We heard about that at the quality governance group. So we've been looking at that as a trust, what we can do differently and improve that. I think what we need to do, based on obviously what we were hearing about yesterday, is strengthen that obviously around maternity and neonatal. So we'll bring that in.
Thank you. If there are no further questions on this item, Steve, obviously you gave a comprehensive written report as usual. Is there anything else you want to verbalise on the discussion we've now had on maternity?
I just, with mindful of the time, I'm saying not happy to say the report as read, but happy to answer any questions on it or provide more.
Okay. Sorry, Jason.
Yeah, apologies, Chair. Just on the report in regards to finance, is there any updates in terms of the signing of the contracts with the trust and other associated activities?
So contract is still not signed, as the local price modification matters are not yet concluded. Leslie, I suspect you don't have any further information on that position at this point. So the key matter we're waiting for is NHS England's advice, guidance or determination on the patient aspects.
Thank you. Thank you. Any other questions to Steve? If not, I'll move on to item 24, the lead governance report. Susie.
Thank you. Taken as read, I hope. And I'll just point out that obviously one of the things that we have discussed quite broadly is the 10-year plan, which removes well, it says it removed the requirement for foundation trusts to have governors, but actually what it's doing is abolishing governors. So we've been sort of deeply in conversation about that. We did discuss it at our last meeting, and we did put it up as a discussion to have with the board today, because the question, of course, is, okay, we won't talk about what's broken, that they think this is the fix. What do we do now? What, of course, has stepped in is the Amos report. So I know we're going to have the problems of fitting it all in, so we might have to do another meeting, but we'll talk about that later on. But anyway, as read, any questions? No.
Thank you, Susie. Any questions for Susie? No. Thank you for all that you do, and thank you for your report, Susie. We're turning to item 25, the maternity update report. Lynn.
Thank you. So I'm going to handle what you've gone there, Susan.
No, I'm here.
So just to hand over you for the maternity update report, please.
Thank you. I'll take the report as read. The key headlines from the report. We've started preparation work for the new strategy. I'm hoping to present a framework at the next QUAC. My second point is that we've now received the full rebate from the maternity incentive scheme of £356,000 to spend on quality and safety initiatives. In terms of the maternity and neonatal improvement plan, we've now got 101 out of the 102 actions now completed and signed off. The last one is the neonatal badgernet, which we're working on, and we've just redated that because we've now got over the hurdle of some of the initial problems that we had. Our fill rates at the request, I think it was the last QUAC meeting, we've now RAG rated them to make it a bit clearer. But just a caution, we need to make sure that we look at the fill rates in the wider context of occupancy and acuity. This is reviewed at twice daily safety huddled, and various measures outlined in the paper ensure that safe staffing and that there's assurance. We triangulated the fill rate data with clinical incident data, and there's been no incidents or complaints that show staffing was a contributory factor. In terms of mandatory education, the year 8 requires us to submit training compliance at 2 checkpoints now, and the second checkpoint is our discretion. So we're going to submit in August, which will include compliance up to the end of July. I just wanted to provide an update on the postpartum hemorrhage. So with the exception of one of the items on the action plan, all actions are now complete, and there's been no further incidents at FGH around postpartum hemorrhages over 2.5 litres, and actually our postpartum hemorrhage rate above 1.5 litres is coming down nicely. And that's it from me. Thank you.
Thank you, Susan. Any questions for Susan? Sarah.
Thank you. Thanks, Susan. So no questions actually, but just to confirm that we did consider these reports at Quality Assurance Committee. There's nothing to escalate, but I did want to confirm Susan noted that there's still one action outstanding for the action plan, which relates to badgernet. So we did test with Susan her confidence, given that that programme has been delayed by 2 years, and now we have a trajectory. So Susan's confidence in our ability to deliver, and we received that reassurance because actually now resources have been allocated to the project, and so therefore the work can commence. So I just wanted to provide that additional assurance really for the Assurance Committee this week.
Thank you, Sarah.
Thank you.
Karen.
Oh, thank you. And apologies if this has already been covered at QUAC. It's in relation to the maternity incentive scheme. And I understand that from year 8 going forwards, the regional oversight, scrutiny and sign off that we're familiar with will be ceasing, and it will become our trust organisational responsibility to do that. It was just a question as to whether we have the robust kind of capacity process so that we can be really confident at board assurance level that we've replaced what has previously been regional oversight. But you may have covered it at Quack, so apologies if it's already been addressed.
Sarah, do you want me to answer that?
Yes, I suppose if I respond to say we didn't specifically address that at Quack. So Karen, I think it's a really good question, especially because I think one of the things when we had the CQC inspection previously and it was being downgraded, that I think we had an over reliance on our own assessment of our performance. So I think it's a really good question, Karen. So I'll now defer to Susan.
Thank you. So all of the MIS actions have been mapped out, and we have a monthly meeting, which actually the LMNS is still invited to, and we evidence every time we say we've achieved something, there's the evidence sat behind it. So we're happy for that to be scrutinised. We are also working with the chief midwife around what that looks like from a regional perspective as well.
Okay. I just wonder whether as a board we just need to be asking something slightly differently than we may have historically when we'd been able to have the confidence of the regional oversight brought us in terms of assurance. It may be something for us to think about.
Yep, we will take that away. If there are no further questions, Susan, thank you so much for joining us.
Thank you.
We will now turn to item 26 on the agenda, biannual mortality report. Chief Medical Officer Colin.
Thank you, Chair. I'll take the report as read. I just want to highlight a few areas. So firstly, our summary hospital level mortality indicator, or SHIMI, is reported there at 135.4. That is obviously behind, and we know that this is a rolling indicator which gives us the data over a 12-month period. And also you can see from there that we previously reported 9 red alerting groups in terms of these specific, which has now come down to 7 red alerts. But I just wanted to flag that we are continuing to see progress against this, and I'll come on to the reason why in terms of coding. But the most recent rolling SHIMI is actually 131.79, which is based on the data from February 25 to January 26, and that's the most recent that's been reported. And at that point, so the most recent, we actually have got down from the 9 to 7 to now 4 red alerting groups. So we're seeing continued progress against that from the 9. And we previously discussed in board that this is related to our reduction in the number of expected deaths rather than an increase in the number of observed deaths. And I think you can see that where we've put some of the crude rates in terms of mortality rates rather than that ratio, and that's on page 101 of the report. We've also within that, because I know there were a number of questions previously, put in information concerning coding, including an update on the percentage that have now been coded, because we have known that the number of expected deaths has been lower because of our incomplete coding. And as mentioned, we would expect to see that improve with the increased number of expected deaths, as indeed we're seeing that change in position in terms of our SHIMI and HSR. In terms of, just wanted to highlight a few areas again within the report on page 103 in terms of the fracture neck of femur. We were previous an alarm outlier, which had been noted on fracture neck of femur. We've seen significant reduction in that concern, and now coming down to green. We've also presented the improvements that we made around patients who treated post-fracture neck of femur. In terms of the mitigations, well, obviously we see that rolling position change with our improved coding position. Our medical examiners remain aware of all alerting groups. We continue to do more structured judgment reviews with our mortality reviewers than most other trusts, with around 25% of all deaths having a structured judgment review. And also just wanted to flag around no concerns identified for LEADER or the learning disability and mortality reviews that we've done. Happy to take any questions.
Thank you, Hal. Questions? Sarah?
Thank you. So I don't have a question, but it was just to confirm we considered this at the last meeting of the Quality Assurance Committee. And I did just want to flag one of the actions that we picked up. So absolutely on the LEADER part of the report in terms of people with learning difficulties, we noted that the care for people with learning disability did require strengthening, particularly around hospital passports and alerts. And we have the Health Safeguarding and Returns Quality Assurance Committee. So we have asked that progress to improve uptake for those passports is reported as part of their safeguarding reports to the committee, so that we're able to monitor the sort of oversight and improvement around that to increase uptake of use of passports, and so that those are then taken into account when patients are with us. So I just wanted to highlight that as one of the actions we did take.
Sarah? If there are no further comments or questions, I will turn now to item 27, the Integrated Performance Dashboard. I'll turn to Chief Executive Steve.
Yeah, thank you, Andrew. Board members will be well used to this report. So for any members of the public watching, the report provides performance information up to April of this year, month 1, apart from 5 months where that information is more recently available. So that goes up to month 2. The difference in the 2 timings is purely the availability of data. That's what drives that. So the covering report provides the summary in each of those 4 domains for any outlying areas, set out as they are. I'll just check with Lynn and Helen if there's anything you want to particularly draw attention to in the quality and safety section.
I just thought it might be useful to give an update on where we are with the PSERF, because that's obviously, and complaints, because that's obviously causing concern. So I have an updated position on PSERF. So to date, we've commissioned 44. There was 45. One's been decommissioned. We've got 24 ongoing, 15 overdue, but we've actually reduced by 2 today because 2 have gone through the learning response group, been signed off with the ICB. And then the other issue I wanted to raise was around complaints. It shows on the report we've got 0 complaints beyond 6 months. We've actually got 6 at the moment. It's a well-known capacity issue that we've been struggling to resolve. We have appointed additional Band 6 senior case officer, and due to some additional resource being transferred to patient relations, they're about to appoint a second Band 6 from the interview, so it won't have to go back out to advert. We've still got some sickness absence, but we really feel that that'll start to improve over the next few months. With a view, Steve, that your challenge when you first came was around getting to below 3 months complaints by the end of the financial year. We've made that very clear to the team, and that's all really I want to highlight.
So just to cover VT, or venous thromboembolism assessment, so we are below the requirement of 95%. There continues to be improvement based on the quality improvement plan, including agreement through myself and the cohort risk assessment that we did with cardiology, and that will then be rolled out, making sure that we're using data to make sure that this is not just yes, we're exempting, and it has to be based on obviously data and risk assessment. So those figures that you can see there in terms of MEC, surgery and families, and CCDE are 3 divisions. There's already been improvement with surgery and families at 83.7% and MEC's 86.26%, which is before we've actually done the cohort risk assessment for larger groups that would obviously fit that, for example, around some of the day case with the cardiac catheter laboratory. So continued progress being made.
It's really helpful, thank you. And then we've identified in the report the special cause concern area in people, which is around appraisal compliance. Rebecca, is there anything you want to say about that, or any other people indicators?
Yeah, thank you. So this was an action from the last public board meeting as well. So each of the divisions and the corporate areas as a whole have a target to reach 85% compliance by the end of July. And this is a progress we monitor through the performance reviews. So the three corporate divisions are on track to reach that target by the end of July. So I'll just add that and hopefully close off the action.
Okay, thank you. That's really helpful. We provide month 2 finance information, as board members can see. We continue to be adverse to plan. And normally I'd ask our CFO if there's anything you'd like to add in further detail. Leslie, this is your day 3. But actually noting that Leslie led some work with our divisional teams and our corporate teams yesterday with the express intent of closing that gap and helping us to accelerate our improvement journey. So just to check if there is anything you wanted to say with regard to that and the work in hand.
I don't think so, other than on day 3, first and foremost, in front of me is the gap on the WRP. Like Steve says, we spent quite a bit of time yesterday with divisional staff and colleagues. First of all, closing the gap on paper. We've got another all-day session tomorrow, a supported session, where we're going to take the gap towards more assurance in terms of a risk-rated plan and making sure that it's of the size that we need it to be. So that's as far as I've got on day 3. I'm very cognizant that we've reported in month 2, but we've actually closed month yesterday. So I'm very keen to see the overall financial position, not just where we are with the WRP.
Thank you, that's really helpful. And similarly, I'd normally turn to the Chief Operating Officer to add any context to the information that's provided there. The report does absolutely clearly show the performance challenges we continue to face around urgent emergency care, particularly the 12-hour performance and the 4-hour performance aspects. We are, as part of our journey, continuing to maintain a focus on the steps we can take to reduce corridor care, as well as the 4-hour and 12-hour performance. Cancer diagnostics and elective are updated. I think we should note the progress around the elective, which is helpful to see. But is there anything you want to add at this point?
Yeah, no, just I'm trying to get out to all the sites over the next couple of weeks. I did Lancaster yesterday just to see the challenges that the A&E had in Lancaster. It's good to see working with and in terms of the work. And from what I saw yesterday, you could start getting a good grip on the elective side and individual patients, and we reduce those longer waiting elective patients.
Okay, thank you. But very happy to take questions for any board members on any of the
Great. IPR questions. Sarah.
Not necessarily questions actually, but certainly, so one is an observation, but a challenged observation. And then I've got a couple of things related to quality committee. And now the observation is not out of my head. Yes, so in the report, the finance section refers to our deficit position at the end of month 2, and obviously noting that month 3 is just in the process of closing. It then says this is offset primarily through savings attributed to vacancy savings in nursing. So in my 3A's report to board, I've advised that the Assurance Committee is concerned about our ability to maintain safe staffing on wards because of the volume of vacancies we're carrying, which is now over 300 and has grown over the last 2 reporting periods. And again, when we previously were under greater CQC and NHS scrutiny, one of the challenges was our safe staffing. So now we're in a much better position to understand whether our staffing is safe, and our dashboards are telling us we're carrying on to vacancies. And it concerned me that the way in which we presented our deficit being balanced was through the savings against safe staffing. and in that context, for the first time at the last Quality Assurance Committee, we actually did see a correlation between a reduction in safe staffing on a ward, and I won't specifically say which one, and an increase in patient safety indicators that might indicate that there is now a correlation between the level of staffing on the ward and the experience and safety of patients in that space. So it's a bit of a challenge to ourselves really to have a think about what that means for the quality and safety of our services.
So it's a good challenge, and we were challenged at from the chief nurse, so showing a significant number of nursing vacancies, and that, like you said, was narrated as a insurance saving. And we must directly around this that planned saving. So I'm clear it's not. Some of it is a hangover from last financial year and the time lag for recruiting. Most of those posts are out to recruitment. Most of them are critical to safe staffing on the wards. You can see in the safe staffing that our fill rates have started to come down. So we have got an aim to fill all of those posts where we can. So it's not a plan to do that. It just but it is a bit concerning how it was narrated.
Yes, just for clarity for those watching online, RPOM stands for the Regional Performance Oversight Meeting. I'm going to go to Amin and then to Karen. Sorry, Sarah, actually.
So I have got some other points, but if it relates specifically to that point,
So just in terms of assurance from a triangulation perspective, the question was also asked at Finance Performance Committee at the last meeting, where it was noted that the monthly performance in terms of the large contributor to that position was the recruitment side. I think you're right, probably more positioning and wording and phrasing. So yeah, that wasn't the actual driver, but it just so happened to be content.
And I absolutely recognise that. I think it's unfortunate positioning is what I would say. But I think what we've had reflected to us as well through the discussions of the Assurance Committee is that the fill rates are starting to fall because actually the staff aren't able or willing to take on extra shifts, you know, for example, through the bank. So that's, you know, the morale is falling as well because of those pressures on wards. So, and of course that is going to impact on the quality of care, if not the safety of care. So I think it's.
Do you want me to check it? Karen, was your point relating to this specific point, or do you want to come in after Sarah's answer other questions?
No, relating to this specific point. Yeah, thank you. Yeah, thank you. I think Sarah's point particularly as well is pertinent, that this is not just about numbers of staff. It's about delivery of really high quality services and clinical standards. I just wonder if we are getting a sense that there could be a connection between the waste reduction programme and some impact on clinical care, outcomes and experiences for patients. When are we going to consider revisiting the work that we did recently as a board on risk appetite and risk tolerance? We were very clear about what we wouldn't contemplate or wouldn't accept, and very clear about what we may need to have to accept, given what we need to do, challenging though that is. I just wonder, given what Sarah's described, whether we need to be very explicit about when we're going to revisit that work around risk tolerance and risk appetite, once we have some examples that enable us to put that into some really meaningful context.
Helpful question and challenge, Karen, and it links to an extent to the Regional Performance Oversight Meeting. The requirement NHS England have set a single improvement plan, trajectory for improvement, and it looks to the work that Leslie was touching on. That was happening yesterday and happens tomorrow. I think what I would suggest is at the end of July be the time for that review, because that we have clarity by that point on have we been able to cover the remaining financial gap this year, what impact and implications does that have, what level of risk does that bring, how assured are we at the progress of the elective recovery and cancer recovery? What is our urgent emergency care assurance? And I think those things together would then inform, do we need to revisit, review and reconsider other actions? We might want to do that earlier, but I don't think that we will have enough clarity to try to do that over the next couple of weeks. And so that would suggest that it's an end of July timeline and at whatever forum we need to use through our committees and then back to board.
Sounds good. It's just I can see Karen's nodding. So Sarah, do you want to you had other points?
Yeah, thank you. And actually, it's quite a helpful continuation, I think, of some of that discussion. So I think this is probably the first time for quite a long time when I've read the IPR, and it's really started to worry me a little bit in some places. And obviously there are aspects of our IPR which we should always worry about. So it's not to say there aren't worrying aspects, but considering the sort of update to our NOF rating, which means we're now officially in segment 4, and obviously I recognise that might be due to quite small shifts or very specific metrics that might have pushed us into that position. But if I, for example, look at page 167 of the IPR, which is a performance dashboard, and again, this is not a question for Gavin at this stage from a COO point of view. But if you look at that trust level scorecard for performance and look at the actual versus the target and started to put a red, amber, green against that, I think we'd have quite a lot of that starting to red and amber, and more so than previously. And I think in the context of that discussion we've just had about risk appetite, safe staffing, quality and safety, financial challenge, performance, there's a question for me about that balance for us as trust between the cost savings we need to make, performance and access that we need to deliver for our patients, and then maintain the quality and safety of our performance. So as a visual cue, I was going to make a suggestion that for a composite scorecard like that, we might consider rag rating it as colours, because that would provide the visual cue about whether our things may disagree. And I think I would think it would be helpful if we could do the same for the divisional breakdown of the scorecard as well, to help us again understand, notwithstanding we know there are challenges in different sectors. That was my second one, just necessarily need a response. And the third one related to complaints. Really disappointed to hear that we've reached 6 months. We've been flagging that it was quite a big risk for us for a number of months now, policy committee, and also that we knew that was driven reduced staffing in the clinical governance team, and I know since Lynn's taken over that portfolio, over recent months have taken steps to strengthen it. But I think given that this is a statutory requirement that we could close the complaints in 6 months, really disappointed. We have picked that up in the 3A's report, and we've asked for strengthened reporting, I think, for complaints. So we've asked for better divisional breakdowns. We can understand, because we recognise part of the hold up is not just the team managing complaints, but actually divisions being able to review and respond, but also so that we can start to seek assurance and the trajectory as well. So yeah, really disappointed to hear that.
I think the point about refreshing the IPR, so the colour coding, rag rating, obviously there's work underway to update and refresh the IPR, so certainly we will take away your suggestions. I think it's a good suggestion, Steve.
Well, I'd agree with that, and also I think it would be also useful for us to be clear for each of these metrics the trajectory target, because in a number of these instances the target stated is the target at the end of March next year. We must be clear about the move towards that, but there'll be a month-by-month trajectory. We may need to review one or two of the targets outright. So the percentage of open general G&A beds occupied by patients who do not criteria to reside, target being 5%. But that is a very clear visionary aspiration. It would be an extraordinary achievement given the criteria desired on average across all of NHS England. So they also need to consider the target for absolute two. But I think the point about the visualizations.
Nicola.
Yeah, I just wanted to contribute to that. I mean, it's really important that we actually do use SPSS reporting because I think it gives us the quality of information that we don't necessarily get. But I also know that it is quite difficult to make that easily accessible, and even when it goes into wider reports. So I think we recognise that. I think we have discussed this, but not necessarily in public board, about the benefit of being able to align our IPR to the NOS so that we can understand where that is having impact there, while at the same time ensuring that we've still got a balanced reporting mechanism, because the NOF necessarily in itself is quite focused on particular things that nationally we're rightly focused on, but not necessarily there'll be things we want to focus on as an organisation. So I think that would be my comment on where we go forward with our review of the IPR, please. And also, is there an opportunity that maybe some of the more detailed indicators that would inform an overarching strategic indicator, could they be picked up by committees who could do some of the heavy lifting and not just the FPC?
Any further questions on this point in the second part of the science, which 3A's report? Not. Turn to the 3A's report from the Assurance Committee, starting with the Audit Committee report of the 13th of May and the 22nd of June. Nicola.
Thank you, Chair. So 13th of May, that was primarily an opportunity to review draft annual documentation and to give feedback and comment. But we did pick up at that meeting as well that we probably needed to pay some attention to our attendance and quality, and we are putting some, with the support of the governance team, we're putting some actions in place to help us address that. So when we came to the 22nd of June, I'm happy to say that we were in full quorum and we were able to approve on behalf of the Board of Directors our annual governance statement for 25-26, our annual report for 25-26, and our annual accounts for 25-26, and the letter of representation to be signed off duly by the Chair and the CEO and returned to NHS England. The committee also considered our internal audit opinion for 25-26. That provided substantial assurance, as in previous years, but they did emphasise that our underlying control environment as assessed was not really as robust as it has been in previous years, and that has been primarily around the length of time to implement management actions and follow-up actions, and we probably need to make sure that we're having a greater focus on those, particularly in our key risk areas. However, the opinion did recognise positive progress in our approach towards management, to risk management and governance, including the continued development of BAF. Our external auditors, we will not be surprised to know that they continue to report significant weakness in our financial sustainability. And while the Trust achieved its revised planned deficit, in line with that we agreed with NHS England, they did conclude that we remained in a challenging financial position as a Trust and as a wider sector. The external auditors confirmed, though, that they had no significant weaknesses that they had identified in our financial governance processes. But they did say that the arrangements relating to 1LSC should be further formalised in order to reflect the significance of the arrangements and services provided through it. I think that relates to other conversations we've been having. And finally, I think we should acknowledge that we gave thanks to our auditors, and we continue to have a very good and effective relationship with them. But also we acknowledge the exceptional work of the finance team that's had another challenging year. It has had its own staffing pressures, and it's had to deal with transition to 1LSC and to a new system, which for a financial team has as much an impact as it would be if we were moving to a new electronic patient record system. And I think my comment as the chair of audit is to remind ourselves that the financial discipline and risk management is the responsibility of all leaders and managers, and not just our experts, finance team or our auditors and governance teams. Thank you.
Thank you, Nicola. Any questions for Nicola about the audit committee? If not, as Nicola said,
Just confirmation for the board following up from the audit committee, the annual accounts, the income statement and supporting documents were uploaded to the NHS England portal by the deadline. We subsequently found and submitted those documents to the parliamentary clerk and Parliament. One suggested amendment which we're executing. The plan being that hopefully we will have our annual accounts laid in Parliament before this recess, and that means that we'll then be in a position to hold our annual members meeting in September.
Thank you. As Nicola detailed, and the board now just detailed, the recommendation to the board of directors is asked to approve the proposed self-certification regarding the availability of resources, and secondly, to authorise the chief executive chair to sign the statements on behalf of the board and submit them to NHS England. Everybody happy? Good. We will move on to the second 3A's report then, from the People Committee and their meeting on the 26th of May. Karen.
Oh, thank you. Just a couple of points to emphasise here. The first one, the alert that refers to the Freedom to Speak Up service. I see that we have that. We have a more a comprehensive report later in the agenda, so suggest that we pick that up there. And then moving on from there, just to highlight that as a committee, we considered the first report of the Workforce Oversight Framework. This has been produced by NHS England. It's aligned to the 10-year health plan for England and associated strategies. There will be, or we anticipate there will be, workforce oversight meetings with regional colleagues, and that they'll be tailored both formally and informally as that work progresses. Oh, my screen's just disappeared. There we go. So just to draw the board's attention to that, we'll see those reports come through and they're added into the cycle of business. We particularly wanted to highlight some excellent work from our very small but highly effective occupational health team who have moved to a place-based wellbeing model. So that's actually significantly working with our teams in their workplaces, and we will be monitoring the effectiveness and impact of that shift in subsequent meetings. Just a point with regards to the work that Rebecca and Helen together have provided some really excellent leadership for on the sustainable medical workforce. Essentially, one of the outcomes of that work is it's become really clear that the governance spans multiple committees. Although its original reporting for Assurance Home was People Committee, and so we anticipate taking an update at our July meeting to confirm how that reporting and governance will be arranged going forward. So we're really clear we've got comprehensive governance for that. Just with regard to the IPR, I think this is also a point that Sarah raised earlier. The significance of refreshing that so that it better supports assurance and particularly aligns with the refreshed BAF is becoming very important, and we're really looking for some time frames around that. We also considered the Leadership, Equality and Assurance Framework, again, a new report into the committee. Performance against that is very strong, with the exception that we've noted for some time around the limited diversity within board membership. I know that's something we've been very focused on with our recruitment processes, but this just highlights the importance of continuing that focus. And those are the key points aside from what you see in the report. Thank you.
Thank you, Karen. Any questions on the 3A's report from the People Committee? No. Great. We'll move on to Finance and Performance Committee report from 18th of May and 15th of June meeting. Amin.
Yeah, I'll just take us through the most recent one, which is the 15th of June. So some key elements here. One is, of course, the financial position for month two. There's two elements to this. One is ensuring that we are in line with our budgeted plans, so that we can control of what we are spending essentially on delivering services. And the other element is the delivery of the waste reduction program as well. In month two, there's a bit of a variance of about just under £1 million. So we are reported FC 3.4 against a plan of 2.5. Some slight concerns there, as has been picked up earlier, that some of the positioning is as a result of not spending on some of the recruitment, which wasn't intentional, it just what happened. But I think the concern really is more the lack of delivery in the WR, which is a waste reduction program, which brings me on to the next alert, which is that we have an under delivery of that, which is one thing, but we also have a gap in the pipeline. So the target for the year is 30 million. We have about 15 million gap in our pipeline, which is currently being worked on. So that's something of concern. And then moving on to the operational performance metrics, we've been through those, so I'm not really near the point there on those, but we've got some good work in the UEC 12 hours and waste handover as well. So pressures in cancer and diagnostics as well. The other thing to mention, which was clinical coding, I know mentioned by Helen, is the mortality as well. So we've got that on our radar. We've got some trajectories in terms of improvement plans in place, which is the close eye, but improvements have been made in that as well. And then, other than that, I've got nothing else other than really my comments in terms of the narrative, which is the delivery of the WR because it's fundamental really to this year.
Thank you. Amin, any questions for Amin on this report? No. Great. We'll move on to next one, Quality Assurance Committee, 1st of June meeting. Sarah.
Thank you. We've picked up some of the points elsewhere in the meeting. Unfortunately, there are quite a few here, so apologies for that. I think the first thing I did want to flag actually is in the report, but it didn't show up in the IPR. It's narrative as the never events.
Sorry, because we did a shortened version. I didn't mention the never events.
Yeah. So it's, but actually in the SPC they're not showing actually, so that's the it's
I have picked that up, so it verbally it's reported on the exact summary, but it just needed to correlate.
Yeah, so there were 3 never events, 1 in March and 2 in April. I think that's the key. So just as an alert in the report, there was the alert from the Nursing and Midwifery Council related to a national issue to do with applications not being processed correctly. And again, Lynn is leading on in response to that. So I won't go into the detail of what's in the report, but of course, Lynn is leading response to that and is awaiting, I think, an update from the national team in terms of any potential staff affected.
So we haven't had any notification that anybody been affected. No staff have come forward. I had a letter back from the NMC because I wrote to the NMC asking for information as soon as they had it. She's only just picked up the letter, but we haven't had further information.
Thank you. So we, at the Quality Assurance Committee, we've had an update on the North Lancashire South Cumbria breast screening programme. That was something that was we discussed at the April meeting and we received a verbal update in June from Alan's Chief Medical Officer. So there's a mobile unit is launching, or was launched in June 2026. It's due to launch in June. And so we will and a number of actions are in place. So we recognise it continues to be a fragile service, and another update will be presented to the next meeting in August. I did want to pull out the advice relating to a red alert from a QAS visit, so a quality assurance safety visit at RLI Emergency Department which took place. This did relate to environmental disruption from building improvement works, but it was the second red alert that that department's received because we know it's a very pressured environment. So the committee was reassured that any immediate safety issues were addressed on the day, and there's now a medium long-term plan with any short-term actions having been completed. From a quality assurance committee point of view, we're maintaining a focus on the quality of experience of patients in the ED, because of it being quite a challenged environment. It's quite important. We did receive a report on end of life care under an update on fundamentals of care. The committee was reassured that the Community Cancer and Diagnostics End of Life Division is now pulling together a much more comprehensive work plan. But as a committee, we felt that that's not very visible from the assurance point of view, and both non-exec directors and governors have highlighted this as an area that we do feel needs more visibility. So we did agree as a committee that that will come as a substantive item in its own right to Quality Assurance Committee. So we'll receive the work plan probably in September, I think, or early October, and then we'll receive some updates to provide assurance on implementation of the work plan. So I thought that should be board. And the only other thing that I've raised is to confirm that we approved the quality account yesterday. So it needed to be approved by the deadline yesterday. We had an opportunity as a committee to review it by correspondence and provided by the models which have now been completed, and we approved that yesterday. So met that statutory deadline. So thank you.
Thank you, Sarah. Any comments or questions for Sarah on that?
It's partly on Sarah's report, partly on some of the other aspects or might have already captured, is just making sure we're clear enough on the expectations of some of the key issues that have been covered. So I mean, your escalation of the financial gap is clearly a very significant one. Just to test, to go through that report, are we capturing that as a, how are we capturing that? The actions that we touched on, Leslie and the team are coordinating through yesterday and tomorrow will be some of the key actions that get us to the point where we've got confidence that we can achieve break even, not and what that would look like. That feels should be absolutely clear. It's a set of actions that must progress on that. And separately, but it's absolutely related, we must have assurance that the vacancies are raised are not impacting to the detriment of the quality of safety services that we provide. So I just wonder if there's two particular actions we need to just be clear we're tracking through, and then they would come back to the committees and to the board. So just to check that we've captured that.
So some of my analysis, the board assurance framework, but it's fine, we'll cover off there because I think there are some additional areas of assurance and action, the way they've articulated that will either strengthen the narrative or add new ones. Some of the points that I want to pick up as parts of that. We parts of kind of the follow-up actions, then with the executive directors, where we can pick up matters perhaps more informally through the action tracker. New content, but our preferred mechanism is to kind of strengthen the assurance framework and make sure that the content of the assurance framework, particularly where the gaps, additional levels, progress that with the chairs to pre-agenda meetings, so we can then make sure that gets picked up through the assurance structures. I think specifically one of the areas that I want to look at is the financial control, whether or not we've got sufficient meetings and capacity in the next cycle to close that gap. That means there's a big question there. So you know, around the work of the financial sustainability group to be steps on, which we've done previously. Joint conversation progress. We think there's some additional control beyond what we've already got planned for the next quarter.
Okay, so that's a decision now that have been through the routes that you described, and think all your concepts are captured.
Happy. All happy to note the 3A reports. We are running 6 minutes ahead of schedule, but I propose that we start the break a few minutes early and have a slightly extended break. So we're going to break now until 2:30, when we will reconvene with item 28, the Green Plan, which I believe Gavin will be leading on. So we will suspend the meeting now and see everybody at 2:30. Thank you.
I can't hear.
I know it's like that.
We do a gaps before it actually gets heard again. So that's in there. So that's right.
Yeah.
I made a decision back last Friday. I'm sure. Well, it was 2 days.
Exactly.
Which triangulates with this. We keep kicking it down the line, so.